Good morning, everyone. My name is Maida from Sideroblastic University. I'm chair of this session. Dr. Bennett, can you hear me now? Good morning. Today, it is both my pleasure and honor to introduce two luminaries in pathology, hematology, and cancer research. Professor John Bennett stands as titan in the field of medicine. His remarkable contribution leaving an indelible mark of understanding and treatment of disease. As a distinguished pathologist, his groundbreaking work has pushed the boundaries of diagnostic medicine and transformed our approach to addressing hematologic disorder and cancer. Please join me in extending warm welcome to Professor John Bennett, whose legendary contribution continues to shape the future of medicine. The title of the lecture is Dysplasia Under Low-Risk Situations, ICUS, CCUS, CHIP. Start, please.
Hello, everyone. Konnichiwa minasan. I'm John Bennett from the University of Rochester, talking to you today from my home office in Pittsford, New York. I regret very much not being able to attend this wonderful meeting in Kyoto. I've been there several times. In fact, if I had come today, it would have been my 18th trip to Japan over the past 5 decades, focusing almost exclusively on MDS. So we'll be discussing criteria for identification of blasts and dysplasia in patients with MDS, and a brief update on CHIP, ICUS, and CCUS. I have nothing to disclose. So we will cover 6 items on morphologic definitions: blasts, monocytes, dysgranulopoiesis, dysmegakaryopoiesis, dyserythropoiesis, and evaluation of eosinophils. So, dysplasia, what does it indicate? Myelodysplasia is not synonymous with MDS. It's imperative to exclude other causes of transient dysplasia, such as vitamin deficiencies, infections, alcohol exposure, other heavy metals, particularly arsenic, copper deficiency, and some commonly used antibiotics, drugs, and biologic agents, among others. Slides should be made from freshly obtained specimens. Peripheral blood exposed to anticoagulants for more than a few hours may prove to be unsatisfactory. In spite of the advances in flow cytometry, cytogenetics, and molecular biology, cytomorphology remains as the cornerstone of the diagnosis of MDS, having a crucial value in diagnosis, classification, and prognosis. It's important when prognostic systems can't be used. For example, cytogenetics myeloid panel, NGS, may not be available or delayed for weeks, or fibrosis may preclude a blast count in the marrow aspirate. Much of my talk will be based on an international working group on morphology of MDS, consisting of the underlined individuals, many of whom you probably recognize, including Masayo Tominaga from Nagasaki, Japan. Here's a composite of our working group. In the upper left, Dr. John Goaskin, Barbara Bain, and myself, which represented the steering committee working in Dr. Bain's office at St. Mary's Hospital in Paddington, London. On the right, Dr. Zini and Dr. Tominaga, and below, Dr. Brunning, myself, again, Dr. Bain, and Dr. Gillespie from Barcelona. So what are the minimal diagnostic criteria for identifying a blast? Blasts can be agranular or granular. Both have fine stippled chromatin with a prominent nucleolus, but no recognizable Golgi zone. A promyelocyte, the nucleus has become more eccentric. The nucleolus is hard to recognize, but there is a clearly recognizable Golgi zone as you can see in the lower right, and much more prominent as urophilic granulation. So here are some examples. 2 agranuloblasts, a granuloblast here, and some of these cells are large enough so you would have to consider them being monoblasts. We'll talk about that subsequently. Here are the promyelocytes, as you can see, with a Golgi zone here and a Golgi zone here. So agranuloblasts, granuloblasts, promyelocytes. Now, why is this important? Because in every scoring system that's been developed, blasts on a individual basis have a highly significant factor inversely related to survival. So on this collection of cases from Düsseldorf, Germany, in which I reviewed many of these slides, if you have 0 to 2% blasts in the red, all the way down to what we used to call RAB-T in the black, the median survival ranges from 51 months down to as low as 5. And what we found, and this was confirmed by the IPSS revised version, that if you break across the barrier of 2%, 3 to 4% blasts has a significantly worse survival than 0 to 2 in the dark blue, as you can see here. Monocytes. Remember, monocytes are not described as ever being dysplastic. Here, an example of a monoblast. They're extremely large cells, 30 to 40 micron. They have these cytoplasmic blebs, and rarely you can see a few granules. A promonocyte, the chromatin is not quite as reticular or punctate as seen here on the left, and numerous azure granules are noted. The activated or immature monocytes are clearly recognizable as monocytes, with the convolutions here, less granules, but the more mature monocytes can have a few to a moderate number of granules. These are not counted as blasts, whereas these are both counted as blast equivalents. So let's move on now to disc granulopoiesis, published in Leukemia Research in 2014. You must have at least 10% of the cells before calling a case disc granulopoietic. Also, the same criteria apply for dyserythro and megakaryocytic poiesis. I would recommend trying to count at least 50 granulocytes on the peripheral blood smear, preferable to the bone marrow aspirate, and then determining whether at least 10% fulfill the criteria for having disc granulopoiesis. So let's take some examples. Here's a male, 83 years old, a low white count, very anemic, normal platelet count, 8% blasts with trilineage dysplasia, and diagnosis of EB1. And here are a whole series that I'd like you to just focus on the cytoplasm and for the moment ignore the nucleus. These cells have normal expression of granules. This one, even this one, this one, and this one. Agranular, without any granules, A10, A6, A5. A7 and A3 are hypogranulated, but fulfill our criteria for disc granulopoiesis. Now, focusing on the nucleus, we talk about pseudopelga and clumping. Notice how densely clumped the chromatin is in all of these cells. And the one with the blue arrow, in addition to the coarse clumping, have multiple nuclear projections. And any patient with a male or female with greater than 4 of these nuclear projections would qualify as having dysgranular poiesis. Here's another one here in the lower right. Now, there are also cells that are very large that we call macropolycytes. They may have double nuclear mass. They are very abnormal in their morphology, and these can be included in the neutrophils when we count cells. So here are a whole series of these. Notice how large they are. They are even larger than monocytes. They can be binucleated, as in these cells here, separated nuclei, but they're actually normal cells, and you're helped by seeing, and often in these cells, a loss of secondary granules. So, some examples. Agranular binucleated form. Notice the shape. In red is a Pelliger cell with a densely clumped chromatin. Another large binucleated cell, and again, a pseudo-Pelliger-Hewitt cell in the lower right. And again, a giant cell here. Shape alone would clue you into the fact that this is an abnormal cell. Now let's turn to dysmegakaryopoiesis. We use not only Romanovsky stains like Megakaryocytic or Wright-Giemsa, but also the bone marrow biopsy. And I've found over the years that this is extremely valuable and often more useful than looking to try to determine whether one has 10% or more abnormal megakaryocytes. Now, one of the problems with a megakaryocyte is that it is a hyperdiploid cell. It loves to divide with multiple differentiating nuclei and changes in the cytoplasm. And in doing our study, we recognized some 12 different forms of megakaryocytes that you may see in a bone marrow aspirate. And in orange, I've indicated the two that are most likely for you to recognize as having dysmegakaryopoiesis: the immature and mature micromegakaryocyte and the multinucleated megakaryocyte with two or more clearly separated lobes. The others are of interest and can be seen, but are much less common and can actually be seen in reactive states as well. So, for example, micromegs. Numerous individual single nuclei, as demonstrated here. Prominent vacuolization in the blast category. 1A and 1B are the most immature blasts you can see in acute megakaryocytic dysplasia or even in acute megakaryocytic leukemia. And they have the vacuoles and multiple cytoplasmic projections. Here's a patient with deletion 5q, the Wright-Giemsa stain on the left, and you can see these characteristic monolobated nuclei. This is a mature mega, and this is an immature mega, seen here in a cluster. The same patient on a bone marrow biopsy, stained with hematoxylin and eosin, monolobated here, 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 and here, clearly more than 10% of the megakaryocytes. Now let's turn to dyserythropoiesis. This is taken from a wonderful article by Lorraine Florenza, published several years ago, showing the developmental sequence of erythroid precursors from proerythroblasts to basophilic erythroblasts to polychromatophilic and orthochromic. So we studied bone marrow films from 20 cases selected for their capacity to illustrate the range of dyserythropoiesis that can be observed and the difficulties encountered in the evaluation of dyserythropoiesis. These are the criteria we focused on: megaloblastic change, multinuclear and asymmetrical or unequal nuclei, nuclear bridging, internuclear bridging, karyorrhexis, vacuolization, and ring sideroblasts. So here's a montage, if you will, of patients with proven MDS or AML, showing multiple abnormalities: trinucleation, prominent vacuolization, giant cells, persistence of the nucleus in a giant polychromatophilic megaloblast, a very bizarre orthochromic megaloblast, fine dust-like chromatin, often called a bag of worms, a nuclear bridge. And you would look at this and say, well, this is very straightforward. If I have this, I must have, or I should have, MDS. Unfortunately, this is taken from non-neoplastic patients, including patients with CDA type 1 and 2. And if you look through that, you'll see that you can find the identical changes in morphology in clearly patients that are non-neoplastic. So here's a patient with B12 deficiency. Notice the delicate chromatin, fragmented nuclei that look like Howell Jolly bodies. Here's a patient with REB, a patient with arsenic, a patient with EB2, both of these fields, and you can see that you could easily substitute one for the other. This is a picture of a recent patient of ours with pure erythroid leukemia with over 30% proerythroblasts. As you can see, the proerythroblasts here, and then the cells mature a bit down to basophilic erythroblasts, but very few orthochromic or polychromatophilic cells. All right, now let's focus on sideroblasts. We talk about type 1, less than 5% siderophilic granules. Type 2, 5 or more, but not ring. And this is very difficult because some view if you have lots of granules and they don't surround the nucleus, then maybe you should call these rings. We think we have no data to support that. Type 3 is the classical ring sideroblast, in which 5 or more granules occupy at least 1/3 of the nucleus circumference, perinuclear, or ring. Here's a cartoon showing 3 different ways that you can have ring sideroblasts: here, here, or here. So here's a patient with RARS, with multilineage dysplasia, teardrop erythrocytes, some target cells, a very dysplastic granulocyte, a bone marrow that shows clear-cut megaloblastic change, and numerous ring sideroblasts that was SF3B1 mutated, numerous granules surrounding the nucleus. This is an abnormal siderocyte in the upper left. So we found between the 7 of us good agreement on the presence of absence of specific dysplastic features. Not really a problem. But our study highlighted the difficulties in assessing dyserythropoiesis and the lack of specificity for myeloneoplasm. So when MDS is suspected, dyserythropoiesis cannot be assessed in isolation. Rather, assessment must be in a clinical context with consideration of features of other abnormal lineages and a constant awareness of other possible diagnoses. And finally, just a word about eosinophils, published recently by us in the British Journal of Hematology. These are very abnormal eosinophils. Notice a marked vacuolization and a nucleus that is now at the metamyelocyte stage. Another example here, microcally hypogranular. Binucleation is fine because that's the normal eosinophil, but a loss of at least 25% or more of the cytoplasm, the specific eosinophilic granules have almost disappeared. Here's a trinucleated eosinophil and a binucleated eosinophil with definitely abnormal nuclear components and virtually no granules in the cytoplasm. So here's a patient with chronic eosinophilic leukemia that a FIP-IL1 PDGF-RA gene fusion, and you can see the very abnormal eosinophils in this peripheral blood smear. Here is another patient with all molecular markers negative. No fusion gene, no BCR-able fusion gene, and again, these very abnormal appearing eosinophils, the hallmark of chronic eosinophilic leukemia. However, these can also be seen in idiopathic hypereosinophilic syndrome. So major WHO classifications still based on morphology. New names for disease entities better reflect how we diagnose them. Molecular mutations will increasingly impact diagnosis and prognosis. In the remaining time, let's look at some of the newer data on what we are calling pre-myeloid clonal states. And it's very imprecise between clonal cytopenia of unknown significance and low-grade MDS. There is a borderline, and often this is a problem in reproducing morphology by several investigators who come up with different degrees of numbers as to whether there is dysplasia or not. One also has to consider subsets of aplastic anemia, PNH, and the VEXA syndrome. The vast bulk of patients with MDS are fairly easy to diagnose. And then as you begin to reach the 20% barrier, we used to say RAPT was 20 to 30%. Now we say that's AML. And more recently, definition of 10 to 20% blast using the term MDS AML overlap. So originally, back in 2007, we came up with the concept idiopathic cytopenia of undetermined significant, or ICUS, versus low-risk MDS, the diagnostic interface. And this was done in the pre-molecular mutation period. And the patients we studied did not have chromosome aberrations. They had unexplained cytopenias for several months and did not fulfill the morphologic dysplasia characterization for having at least 10% of one cell line. And in this group of patients, we had approximately 5% who evolved to overt MDS within a period of 2 to 3 years. So what is clonal hematopoiesis of indeterminate potential, or CHIP? No evidence of a morphologic neoplasm. Mutations at a variable frequency of at least 2% involving all of the genes that we see in myeloid neoplasms. And the odds of progression to overt neoplasm are less than 1% per year, very similar to MGUS. So non-clonal ICUS, there is no clonality, there is not dysplasia, there is cytopenia. This is ICUS. And my feeling is now with all the molecular mutations we have, we probably will no longer find traditional ICUS. CHIP, we've talked about, very low evolution to a myeloid malignancy, and CCUS has cytopenias. So this separates CHIP from CCUS, the presence of cytopenias. And then we have lower risk MDS and higher risk. Last year in Blood, Dr. Aber and their group with the International Consensus Conference described for the first time a variant of clonal cytopenias involving the monocytes. Persistent monocytosis with monocytes greater than 500, now lowered from the 1,000 or more tendinite cells, and at least 10% of the cells being monocytes. In the presence of at least one myeloid neoplasm, no dysplasia, no increased blast, or morphologic findings of CMML. This is a series of 4 different reviews by 4 different authors of the proportion of carriers that have CHIP. And you can see that there is a gradual increase up into the 90s, where close to 20% will have 1 or 2 myeloid mutations. Now, these CHIP genes have a different proportion of mutations than one sees in either MDS or AML. So there's a much higher, considerably higher prevalence of DNMT3A versus, for example, splicing genes or SF3B1. So the incidence is different than what we see in myeloid disease, but we see the same type of genes implicated in either epigenetic regulation, splicing, or DMA damage. And the risk of transformation to MDS is dependent in red on having high allele burden and most likely having spliceosome mutations. So this combination causes a considerable increase in the development of overt MDS. So 10% of healthy individuals over 65 do contain somatic MDS type mutations. Mostly of these, the allelic burden is usually 10% or greater and clearly associated with an increased risk of subsequent hematologic malignancy and death. There is a lot of controversy as to whether one should consider patients who have 1 or more of the mutations that we talked about and a high allelic burden, having pancytopenia, but no dysplasia, no increase in blasts, and whether we should offer these patients intervention with chemotherapy or other agents. And in red, I've highlighted this is still very controversial. And finally, I highly recommend this recent article in the New England Journal by Weeks and co-authors from the Dana-Farber Cancer Center and from the Italian group with Luca Malcavati. What they've done is taken an enormous database of several 100,000 individuals in Great Britain who had data banked for a variety of different reasons, and the cumulative indices of myeloid neoplasms with no CHIP or CCUS is in black. Nothing happens. CHIP, a very slight increase up to 12 years, and a significantly higher increase in CCUS at 10% level. And these are the types of myeloid malignancies that were seen in this group over the period close to 150 or so, over this period of 12 years. Now, if you take the same survival curve that I showed you before and look at the multivariate analysis, age, CCUS, RDW, which we find in all of our hemograms, have a significant adjusted hazard ratio, and MCV, high-risk mutations, but not the presence of DNMT3A and increased mutations. And you can see where we're going with this. There now is a scoring system that you can take your patients with CHIP or CCUS and predict with great accuracy what the likelihood of developing a myeloid malignancy over time. So that concludes my talk, and I thank you very much for your attention.
Okay, thank you. I received a message. Sorry, time is up. So if you ask something to Professor John Bennett, please send an email.
Okay.
Sorry. Finally, I would like to express our gratitude for Professor John Bennett's contribution to Japan. Thank you. I will now bring this session close. Thank you.